Good evening, everyone. I'm Dr. Lori Peek, the Director of Veterinary Programs for Maddie's Fund. We want to thank you for such a great turnout for a topic that can sometimes be intimidating or overwhelming, the use of data in animal shelters. At Maddie's Institute, we believe using and understanding data about our animals and our organization is essential to saving the lives of all the healthy and treatable pets in our shelters. That's why we're presenting a two-part series, Saving Lives by the Numbers, How Data Shows the Way. Tonight's webcast, Magical Metrics and Dazzling Data, How Medical Fact-Finding Guides Shelters to Improved Animal Health, is the first in that series, and we're very proud to have Dr. Jan Scarlett as our presenter. In addition to being Director of Maddie's Shelter Medicine Program and Professor of Epidemiology at Cornell University College of Veterinary Medicine, Dr. Scarlett is a member of the National Council of Pet Population Study and Policy and the Shelter Medicine Specialty Organizing Committee. She's also the author of over 100 peer-reviewed publications, and her current interests include using data to enhance the care of shelter animals and to prevent pet homelessness, including the effectiveness of spay-neuter programs. Before we get started, there are just a few practical things we need to cover. Those of you attending this live webcast will have the opportunity to win one of 10 door prizes, a copy of Maddie's Infection Control Manual. We will draw the names after the webcast and will notify the winners via email, so good luck. Next, please take a look at the lower left-hand corner of your screen where you'll see a Q&A window. That's where you'll be asking questions during the presentation. Dr. Scarlett will answer as many of the questions as she can at the end of the presentation, but please don't hold your questions until then. Ask them all during the event. Questions asked in the last few minutes will probably not get processed in time for a response, so get yours in as soon as you can. If you need any help with your connection during the presentation, you can click the help icon at the bottom of your screen or go to event.on24.com/view/help. You'll also see other fun little images at the bottom along with the help button. These are widgets that will take you to the resources our presenter wanted to share with you tonight, as well as some shared by Maddie's Institute. Please be sure and check them out. Before I turn things over to Dr. Scarlett, I wanted to say a few words about Maddie's Fund. We are the nation's leading funder of shelter medicine education, and it's our goal to help save the lives of all our nation's healthy and treatable shelter dogs and cats. The inspiration for that goal was a little dog named Maddie, who shared her unconditional love with Dave and Cheryl Duffield. They promised her they would honor that love by founding Maddie's Fund and helping make this country a safe and loving place for all her kind. Please use what you learn here tonight to make the dream she inspired a reality. Dr. Scarlett, thank you for being here with us this evening.
Hello, everyone. I wanted to, before we begin, thank Dr. Peek and especially Lynn Fridley for helping set this up, for inviting me to speak, and helping with the headset and all of the technology that goes along with being a speaker here at the Maddie's Institute.
Oh, you're welcome.
I want to confess to a little angst over the title, Magical Metrics and Dazzling Data. I pondered whether I should be talking about the numbers of relinquished, retired magicians' bunnies or graphs of silver and gold futures. Unfortunately, if that's what you were expecting, you're going to be disappointed. Instead, I'm going to talk a little bit about some data, using data to improve the health in animal shelters. I am using this slide, and I use this slide actually when I speak with the veterinary students to diffuse some of the anxiety that they often express when we begin to talk about metrics or statistics of any sort. Also, the pictures reflect some of my anxiety when I was thinking about making this presentation. I'm perplexed that the data that you will need to do many of the analyses that I'm talking about are not yet easily available in many of our shelter software packages. And it was kind of a chicken and an egg decision that if I could wait until it was available, but by hopefully interesting you and building some excitement in doing these kinds of analyses, you can help me and others put some pressure on the software packages to make these data more readily acceptable so that you can do the things that I'm going to show you, some of the things that I'm going to show you tonight. Also, I think that we don't have all the answers yet as to exactly what are the best medical metrics to use. And as we go through the presentation, I'll try to highlight some of the questions that I have about where certain metrics might be best. And having said that, I think we still need some good research to help us better understand which of these metrics are most helpful for the questions that you are most interested in asking.
Okay, so here we have a poll question. Does your shelter enter medical data into some type of computer software program? For example, PetPoint, Chameleon, Excel? Yes, no, don't know, and not applicable. Answer. Okay, so it looks like 54% of you said yes, 17% said no, 10% said don't know, and 19% said not applicable.
53% of you are collecting data. That's good. One of the things I really want to make a point is that data collection is time-consuming and it's expensive. And even though many shelters use PetPoint and they didn't have to pay to get the software, there are other shelters that are paying for Chameleon or Shelter Buddy or other software packages. But even if you get your software free, shelters are paying staff during the training time that they use to help people learn how to put the data in and the actual time that they're putting the data in. And I'm afraid that in many cases, shelters enter a lot more data than they ever use, and it gets to a point where they're in fact entering data for data's sake. I think what we really want to think about is what kind of data do we want to put in because we're going to use it. We're going to use it in some way to influence our thinking or our actions in the shelter. And I'd really encourage you, if your shelter isn't already using medical data, or in fact if it is already using medical data, but you're putting a lot of information in and you don't have any plans to really use it, be thoughtful about what you're going to use the medical data for. What questions do you really want to answer about that you need to help you manage either the health of the individual animals or the population of animals in your shelter, and be parsimonious. Better to collect really good, complete data on a few things than to try to enter everything you possibly can think of and then do it poorly. The other thing, of course, is it has to be accurate and it has to be complete. If you have 50% missing pieces of information on your diagnostic data, then the question that begs the question: are the data that you have representative of all of the data that would have been there had you put in the other 50%? We always worry about biased entry of data. Did you put these in because they were particularly egregious cases, etc.? And if you're going to strive for accurate and complete data, then you have to train your staff and you have to monitor whether they're doing what you trained them to do. You then have to periodically retrain them to remind them about why you want to collect that information and how best to do it. And then I think you really ought to reward them. In their performance reviews, reward them for doing that well. So how can we use data for medical purposes? One way to do it is to use it for the care of our individual animals. So Dr. Peak already mentioned several examples of that: scheduling vaccinations such that the computer reminds you that this animal now, it's 2 weeks later and you want to revaccinate. Similarly, wormings, how many treatments does this animal need to get? How long, when do they begin, when do they end? Certainly you're using, in many cases, in many shelters now, the medical data that's entered into the computer is actually the medical record. And so when you change treatments, or if you want to go back and review the history, you look at the computerized software. And then adherence to protocols. If you have assigned this animal to receive doxycycline for the next 10 days, is that actually happening? Are people actually administering the drug according to your specifications?
Okay, so here we have another poll question. Does your shelter use computer software to help manage the care of individual animals? For example, scheduling vaccinations, treatments in the shelter. Yes, no, don't know, or not applicable. Okay, so it looks like 47% of you said yes, 21% said no, 11% said don't know, and 22% said not applicable.
So presuming of that 50-some% that were entering medical data, that among those 46.6% were that percentage were among those, then it looks like a very high proportion of those of you who are entering medical data are in fact using it for individual animal care. All right, so the other way we can use medical data besides individual animal care is for the care of our population and to monitor and review the population health. And one component of that, of course, is disease surveillance, to evaluate trends in disease frequency, to be able to diagnose outbreaks, and to assess the disease burden in your shelter. We're going to talk about a number of these other things, so I won't go through these right now, but we're going to talk as we move forward about things like identifying high-risk groups or identifying factors contributing to disease.
Okay, another poll question. Does your shelter keep track of the length of stay of its dogs and cats? Yes, no, don't know, and not applicable. So does your shelter keep track of the length of stay of its dogs and cats? And so this means from the day the dog or cat comes into your care or into foster care, we don't want to forget about foster care, until the time that it leaves. So how many days does each animal spend in the shelter or the rescue group? Yes. All right, so 64% said yes, 8% said no, 9% said don't know, and 18% said not applicable.
Well, that's really excellent that so many of you are using length of stay. As we talk a little further tonight, we'll see that length of stay is one of those metrics that has a real relationship between the risk of disease in relation to the time that animals spend in shelters. So talking about using medical data, obviously as a veterinarian, you're going to be using these to help make medical decisions. But I also would like to suggest to you that, the first line of defense in any animal shelter in the prevention of infectious diseases are the staff that are doing the cleaning, are the staff that are handling these animals. And if we can engage them and make them recognize that part of their role, part of their job description is to help keep animals healthy. And I think one of the ways we can do that is to say, hey, last year we had 30% of the cats walking through the door develop URI. And because of your adherence to the protocols, because you were part of the team that was acting to try to prevent disease, we've dropped that this year to 27%. And I think it's a real opportunity to both engage them in and make them think they're part of the healthcare team, but also to motivate them to continue the good work. Certainly reporting to management, I think if we can get our management to begin to think about the health of the animals in the shelters as something that they are promoting and they are funding and they are sharing with the board of directors, that can help you to convince management and the board of directors for more resources. Justification for more funding, we see more and more funding agencies wanting to see some evidence in your proposals for money for spay-neuter or whatever. Can you actually measure an effect? And other things like ordering medical supplies. So the objectives today is really, if I do nothing else tonight, I'd like to encourage you to begin to think about using your medical data more extensively than you currently do to improve the health of your shelter populations. And I'm going to share some data use examples that could enhance health care in your shelter. I want to take a few minutes and talk a little bit for those of you who either don't remember or have never been exposed to calculation of prevalence and incidence metrics, and then share some insights that we've gained as we've begun to work with data from several shelters. So before we do that, I want to talk a little bit about caring for individuals and for a population, and contrast those two things. They actually have a lot of similarities. When you do a physical exam on an animal, you're looking for signs of disease. And when you look at an analogous way of looking at how healthy is a population is actually to look at the frequency of disease. So a shelter that has 30% of its animals of its cats develop URI is a less healthy shelter than a shelter that has only 5% of their animals develop URI. When you're looking at an individual animal to help you diagnose that disease, you frequently run diagnostic tests. One of the ways to get a handle on what might be causing the disease in your population is actually to begin to look at disease rates by age, by length of stay, by neuter status. So you're going to subgroup, look at subsets of your population and look at their disease frequency rates. And then you're going to develop a plan for treatment. In the case of the individual, for a population, if you see a very high incidence of disease, you're going to develop a protocol and a plan for trying to reduce that. Once you have that in place, you're going to implement your plan on the population, and you're going to implement your treatment in the individual animal. And in both of those circumstances, whether it be in the individual animal or in the population, you're going to look for evidence of effectiveness. In the case of the animal, hopefully it's the disappearance of clinical signs. In the population, hopefully it's a reduction in the amount of disease. And then using that information and what you've learned for it, hopefully in the case of the individual animal, you can take measures to prevent this animal from developing that disease in the future. And similarly, you can take actions to either sustain the lower level that you have now in the population of disease, or you can actually make plans to drive that frequency of disease even lower. So I've said some of this, but I want to talk a little bit more specifically about establishing the baseline frequency of disease in your shelter. Again, we'll talk about disease surveillance, and I'll go down through each of these other factors. There are bullet points that I have on the right-hand side of the screen. So baseline frequency of disease, or taking the pulse of the population. Before we talk and look at some data from a particular shelter, I wanted to remind you about the difference between incidence metrics and prevalence metrics. Incidence metrics measure the probability of developing disease, or the risk of developing disease in a population. Prevalence metrics measure the probability of having disease, whether they developed it in the time frame you're talking about, or whether they came in with that disease, or they actually had it at the beginning of the time frame. And the choice of an incidence or prevalence metric depends on what your question is. Notice that both incidence and prevalence metrics are talking about clinical cases. You can do incidence metrics to look at the incidence of infection or the prevalence of infection, but of course in our shelters we don't routinely culture and or run PCR tests to identify animals that have or are developing a particular infection. So what I talk about for the rest of our time together will be actually incidence or prevalence of clinical cases. So this comes from a shelter, their data from 2010, and this is, I'm going to draw your attention first to the heartworm percentage under dogs, the heartworm percentage under sarcoptic mange, and the feline leukemia percentage for cats. All of these are prevalence measures. These were the proportion of animals that had proportion of dogs that had heartworm infection at the time they entered the shelter. Sarcoptic mange, similarly, the proportion of dogs that had sarcoptic mange when they entered, and among cats, 1% of those cats coming into this shelter tested positive for feline leukemia at the time they entered. Oops, I meant to go back. Sorry. The rates that you see, or the measures, the frequency measures that you see here for coccidia and for giardia and for URI are in fact incidence measures. They're actually newly diagnosed cases that occurred in this population during 2010. What diseases you have on your list are the ones you're most interested in, the ones that you think either are the ones you see most frequently in the disease in your shelter, or the ones that you want to work on in your preventive medicine programs. So that's up to you what you want to put there. This disease surveillance is the ongoing monitoring of disease frequency. And so we can monitor trends over time, or when you recognize that an outbreak is defined as a significant increase in the frequency of disease over that which is usually observed, you see that you have to have some kind of baseline measure in order to recognize that you're actually in an outbreak situation. And again, we talked about the importance of sharing this information, not just with the medical staff, but with all other people in the shelter that actually handle or work with animals and can affect the health of those animals. So let's look a little bit closer at evaluating disease trends over time. Again, it's up to you. What are the questions that are of most interest to you? Are you wanting to track the prevalence, for example, of URI in your shelter over the next several years? Or perhaps you want to take a look at it at a seasonal level. So take time and think through what you most want to know. So let's look at some shelters' data. I was going to say that these were real data. Actually, some of them are real data, but I got frustrated because some of the information that I wanted to illustrate some points with you tonight, in fact, I couldn't easily get out of PetPoint. So I have to confess that I've manufactured some of these data. So in your notes, you're going to have these data. And what I'm going to do over the next several slides is look at several examples. And all of the examples are going to build on the numbers in this table. So if you can't follow all of what I say in the next few minutes over the examples that I show, you can go back after we finish tonight or tomorrow and go through and see where the numbers were that I was using. All right, so the first thing I want to talk about is prevalence and how you would calculate, for example, what is the prevalence of FELV among cats walking into your shelter. So one question that you might want to ask is, has that annual period prevalence of FELV infection changed among your cats between 2010 and 2011? And in order to calculate this prevalence, you need information on how many cats were tested for FELV, and among those, how many of those animals actually tested positive. And then I usually multiply it times 100 to get a percentage. So very straightforward. In 2010, in our hypothetical shelter, 34 cats that were tested were, of the 1,138 cats that were tested, 34 were positive, so that meant that you had a 3% prevalence walking through the door. Similarly, in 2011, that number was 2.8%, and you don't need a statistical test to see that the prevalence level hasn't really changed. Let's change the question a little bit and talk about the annual period prevalence of feline upper respiratory tract infections and ask whether it has declined between 2011 and 2010. And in order to do this, you need the number of cats with the diagnosis of feline URI, the date that each of those diagnoses occurred, and the number of cats at risk for having URI. Now you can say, well, where will I get that information? You have to enter it into the software package that you have. I strongly recommend that you use, we use PetPoint. I'm not as familiar. I unfortunately can't answer questions about individual software packages, but I can tell you that what you're striving to get is the number of cats with the diagnosis of feline URI. You'll then need the date of each diagnosis of URI, and you're going to have to put that in at the time that you actually make the diagnosis, and then you're looking for all those cats that were in the shelter that could have had a URI infection. So who's at risk in the shelter of having URI in a year? Well, those cats that were present on January 1, who were going to continue in that year in the shelter, plus those animals that were entering the shelter throughout the year. I'm going to pause a moment and just give you a great big caution. I strongly suspect that many of you do not know who is counted or what kinds of animals are counted in your intake numbers. This is from a shelter we're working with. They have all of these categories in their intakes. And now the question becomes, what's your question? What question do you have, or what question do you want to ask, and to whom and what subgroups do you want this question to pertain to? So you might want to know, well, what is the URI rate in stray cats? And you might want to compare that to owner-surrendered cats. So if that's the case, then the denominator for those rates, respectively, ought to be stray cats and owner-surrendered cats. If, on the other hand, you just want to know in the shelter, regardless of whether they came in as a bite hold or a seizure or a service in, I want to know if they spent some time in my shelter, what proportion of them had URI. Beware, some of your intake categories might include things like animals coming in from the public for spay-neuter, where they might, in fact, come in for only a day, come in, be spayed-neutered, and go back out. I would suggest to you that in most cases they're not part of one of your questions. So I think what you want to do is remove those animals if they're counted in your overall intake before you look at the actual prevalence rate in animals that you were interested in, that is, those that were spent some time in your shelter. So this is just to show you that you can get in PetPoint, for example, and I'm sure you can in Chameleon as well as Shelter Buddy, you can actually get the numbers of cats in a particular year in each of these intake categories and the percentages. And when I'm calculating the prevalence measures, or if I'm calculating incidence measures, I'm keeping those on hand so that I can be sure that I'm using the appropriate denominator in my calculations. So for calculating period prevalence with the example that we gave, and I pointed out that table earlier in the presentation, we had in 2010 291 cats that had URI at some point in the shelter out of the animals that came in plus the animals that were still in shelter. So that for a period prevalence rate of 291 cases sometime during 2010, divided by the animals that came in, the intake, 1,580, plus those still in shelter on January 1, 2010. And then similarly, we did the same thing for 2011. So if you compare these two period prevalences, in fact, they look very, very similar, and you would say that, in fact, no, you had not experienced a decrease in the period prevalence. When you go to ask a question about incidence, getting the appropriate data gets a little bit trickier, because now you're asking about the risk or the probability of getting sick among those animals that are at risk of getting sick. And so now that numerator is going to include only new cases of disease, that is, those that were first diagnosed in the interval, plus those animals that are truly at risk of developing disease during that interval. And so a question might be, has the annual incidence of feline URI declined in 2011 compared to 2010? You're going to need data regarding the number of animals that developed, not had, developed, newly diagnosed cases of URI. And you're going to need the date of that diagnosis during that year to verify it happened in that year. And then you're going to need the number of cats at risk in the population for developing URI. So in our example, again, let's talk a little bit at who's not at risk of developing URI in a given year. Well, those that were still in the shelter that had URI on January 1 are not at risk of developing disease in January or in 2010. And similarly, maybe those that had URI in the previous year. Data regarding multiple infections and whether or not cats can acquire two different episodes or have two different episodes of URI is one I think we don't have an absolute answer for. I mean, I think in theory, certainly we know that cats can be co-infected with herpes virus and calicivirus simultaneously, or they can develop a herpes virus infection, recover from that, and then theoretically at least develop a calicivirus infection. Of course, if the animals if you're reducing your length of stay, they shouldn't have the opportunity to develop that second, recover from one infection and develop another. But in shelters where, in fact, the length of stay may be 30, 35 days or more, or in sanctuaries, in fact, they may develop a second disorder. And I think we have to decide, as a prudent approach, I've actually removed them from my denominator, but I think that we don't really know if that's really necessary, and I can't really tell you for sure whether that's the appropriate thing to do. And who else is not at risk? Well, those that entered I already mentioned. If you get really technical and you were doing a research project, I might also say, well, wait a minute, if they came in and developed their URI in the first 3 days of the shelter, they probably didn't acquire it in the shelter. They probably were incubating it when they came in. I think for practical purposes and looking at the frequency of disease in our shelters, we don't have to get that specific. And, in fact, I would go ahead and leave those in. So in our hypothetical shelter in 2010, 1,580 cats entered, and we would remove the 60 that entered with URI from our denominator of who is at risk of getting sick in 2010. And similarly, we would take the same approach in 2011. So population at risk then would include the 216 that were present on 1/1/2010 minus the 40 that either had URI or had URI the year before to leave us with 176. We would take the 1,580 that entered the shelter, remove the 60 that came into the shelter with URI to get 1,520, add those two numbers together, and get the population at risk of developing URI of 1,696. We would do the same thing for 2011. It would be a good exercise for you after the presentation sometime to go ahead and do the same numbers for 2010. For 2011. In terms of new cases that developed in 2010, we take the 291 that had a diagnosis of URI and then remove those 14 cases that were there on January 1 and also the 60 that entered with URI to give us 217 new cases in 2010. Repeat that process for 2011 and then calculate our actual, what we would call annual cumulative incidence rates. And this is simply the proportion of animals that were at risk that developed URI during the period of interest. And in this case, we don't see any real change. Okay, what other kind of animals might not be at risk? It depends on your shelter. I think if you have cats that come in, some shelters actually don't. If they believe an animal is really feral, they euthanize that animal almost immediately, not having to hold it for its stray hold. If that's the case and you have an animal that's there only hours, then I would suggest to you that they probably don't belong in the population at risk. So really look at who do you want your rates to apply to. Okay. So to make matters even more complicated, for those of you who have had epidemiology in your background, it may be that cumulative incidence actually isn't the very best measure. And when I mentioned early on that there is this question, research question, I think that yet needs to be answered, and that is, can we use cumulative incidence, or do we have to get a little bit more technical and actually calculate incidence density metrics? And the way that incidence density metrics differ from our cumulative incidence is they take into account how long an animal has been in the shelter, or that is, how long have they actually been at risk. And so we use, instead of animals at risk in the denominator, care days at risk in the denominator. And I know it's a little bit hard. This is a little bit of maybe a little difficult schematic to understand. But if you look on the left-hand side of the slide, you'll see the numbers. So 015 is the ID number of a particular cat. And that cat, if we were looking at the incidence density of, let's say, URI, in the periods 1 September through December 31st, that cat would contribute about maybe 20, 25 cat days at risk before it gets sick. If that cat remained in the shelter, let's say till mid-November, any days after it actually got sick, it is no longer at risk of getting sick, and so those care days would not go into the denominator. The next cat, 092, contributes somewhere around 45 days of days at risk. It did not get sick while it was in the shelter, and it no longer contributes once it leaves the shelter. And what you do is you go down through every cat that's in the shelter during that period, and you sum up all of the cat days or care days at risk to put in your denominator. So in calculating an incidence density, then, what you're going to do is put the new cases of disease, just like we did with the cumulative incidence, in your numerator, but now you're going to divide it by the animal care days at risk in the denominator. What we've done is begun to play with comparing cumulative incidence measures with incidence density rates to see whether we get the same kind of answers, the same kind of patterns. And some of the preliminary data look really promising. That it looks like we're getting the same kind of patterns, and maybe we don't have to worry about the more involved calculations of incidence density. That said, I don't think that we have a firm answer yet, because I'd like to look at multiple situations over multiple shelters before I would recommend cumulative incidence over incidence density, because these are some data we collected in an earlier study, an actual research study, where we looked at comparing cumulative incidence, which is the percent, and then the incidence density measures, which is the rate per 100 cat days. And if you look, you'll see that individual kittens with cumulative incidence have the lowest cumulative incidence measure, whereas if you look at it by incidence density, they aren't the lowest. In fact, cats that are adults have the lowest. So I think the reason for that is that incidence density measures the speed with which disease travels in a population. And in this case, individual kittens actually stayed a shorter length of time in the shelter, so they're contributing fewer cat days or care days of observation to the denominator. So I think I can't really tell you which is the better measure now. I think if you get started doing cumulative incidence, I think you're going to begin to see that you can see some. Well, let me go on here for a minute. I'll show you. This is one where we actually were using cumulative incidence to look at the risk of developing URI by days in the shelter. And I think here we actually looked at, for day one, of all cats that were in the shelter at day one and at risk of URI, this is the proportion of animals that actually developed URI. On day two, this is among those cats that didn't get sick on day one and are still in the shelter, this is the actual cumulative incidence that developed disease on day two. So these are very clean and accurate measures of risk by day in the shelter. We've also used cumulative incidence to try to track when we implement, for example, protocols that are aimed at reducing length of stay or reducing census, comparing the same time of year in 2 different years, comparing the URI rates. And I think what we're seeing was what we had hoped to see, that is a decline in URI between these 2 time frames. Similarly, in looking at data by URI rates by or cumulative incidence measures by season, I think we're beginning to see some discriminating power using cumulative incidence. What we need to do is go back and check these and look and see if we see the same patterns when we're using incidence density. So stay tuned. We hope to have some of that information very quickly. So another thing to use some of your medical data to do is to identify and investigate outbreaks. And I know that for many of you, you don't normally have canine distemper in your shelter. And in fact, if you get 1 case or 2 cases in your shelter, you know for sure you've got an outbreak, because that's clearly in excess of what you normally would see. And you don't need metrics that have been entered into a software package to tell you that. With feline URI, if you usually have a fair amount of upper respiratory in the shelter, you might have normally 25% of your cats get sick. Maybe or maybe not, you'll recognize you have an increase, a significant increase in that, just by monitoring how many animals are in your isolation ward, for example. Then again, you may not be. You may want to, and it may be harder to discern the jump from 25% to 30% without actually using metrics. I want to show you an example where, in fact, we absolutely needed to look at the metrics in a shelter where a shelter was experiencing an outbreak of incision infections, and we were able, by going back and looking at some of their data, to actually demonstrate they were having an outbreak and to help try to track down why this outbreak was occurring. So just to give you a brief history, this was a call came into us here at Cornell in 2008, and a shelter veterinarian, was convinced he had an outbreak of incision infections in his shelter. He had many more cats, in his opinion, that were developing infections at their spay incision sites, and he wanted to understand why, and of course he wanted to be able to intervene and reduce their frequency. So we started off by just counting the cases over time, and we went back to 2007 and looked at the incision infections that had been entered into his software, and then compared that to the number of cases that he was seeing in 2008. And incidentally, the 1 through 12, 1 is January, 2 is February, 12 is December, etc. So looking at this, it sure looks like he has an outbreak going on, but the question is, did he start doing more surgeries in 2008, and that's why he has a proportionally higher increase in the number of incision infections? So we actually looked at monthly attack rates. That is, among those cats that were receiving or that had been spayed, of those cats, what proportion of them were developing incision infections? And lo and behold, if you look here, there seems little doubt, and if you run statistical tests, there is no doubt that he is experiencing a significantly higher incidence or attack rate of incision infections in 2008 compared to 2007. So we went back and started to break down these attack rates by month to try to get a sense of, was it an increasing rate, was it remaining kind of stable? And in fact, we couldn't really see a pattern over time in terms of increase from July to November. To give you just a little bit more history so you can kind of put this in some kind of a context, this is from a large urban shelter where they handle approximately 10,000 dogs and cats. It's open admission. They have 2 3/4 veterinary full-time equivalents. They have 7 LVTs, and they perform about 3,400 cat spays per year. They have a veterinary clinic within the shelter and a modern surgery suite. They weren't really sure exactly when the outbreak began, but it had begun some months ago. And so what we started to do was to look at some risk factors. And one of the things that occurred to us is that maybe we had more kittens in the shelter, and maybe those kittens were more likely to experience infections, for example. And in fact, we could find no difference in the median age at surgery, nor did we see any difference in the median days to surgery before the time that they actually came to surgery and then developed their incision infections. We looked at the rates by surgeon. That made some of the surgeons a little bit nervous, but in fact found no difference among the surgeons. We then looked at the LVTs that were doing the scrubs before surgery, and look at this a little bit carefully. We looked at this, said, oh, geez, doesn't look like there's anything statistically significant, and I have to confess that I didn't really pick up on it. But if you look here, you'll see several technicians that had rates of 4, 4.5, 4.1. The veterinarian that was involved with this took these data home and thought about it and had one of these epiphanies in the middle of the night where he said, by gosh, those people are relatively new hires. They haven't been with us nearly as long, and while we think we do a really great job of monitoring and training them to do thorough sterile scrubs, in fact, when we divided it by recent hire and experienced, we found a significantly increased attack rate among the recent hires. I don't think we would have found this. I don't think we would have been able to track this down to the same extent that we were able to using the metrics. And in fact, while I can't say for sure that this is the only reason, and we looked at a whole bunch of other factors that I haven't shown you data on, when the veterinarian went back and really did an intensive retraining of some of his techs, in fact, his incision infection rates returned back to normal. So recently hired technicians were 2.7 times more likely to have worked on a cat that developed an incision infection than experienced technicians. So another way to use the metrics might be to help you assess the disease burden in your shelter in ways beyond just using the incidence and prevalence measures, and maybe in some ways easier to use in some of the incidence and prevalence measures. One thing that we were doing in one shelter was looking at the average daily census of sick cats in the shelter. They knew from using the software how many cats they had in the shelter, and then they could calculate by counting the number of animals in the infirmary how many cats they had sick, and they looked and calculated that 7.9% of cats in the shelter each day were ill. And you can do this over a week's period. You could do it over a month's period. If you kept track of it over time, you could compare this time last year, do I have the same proportion or relatively the same proportion of animals spending time in my isolation area? Similarly, you could do it by looking at the average use of your isolation ward cages. That's another suggestion. In some of the software packages, you can actually look at use of, you can look at cats where they are by location in the shelter. Another one we're playing with and really like is the average percentage of the total care days in a shelter that are devoted to sick cats. And I like this measure because I think it not only gives you some sense of the disease burden in your total population of cats, but it also gives you some sense of the time and effort and the cost of taking care of that, of using that many care days to have to care for sick animals. And I think these can be perhaps really persuasive metrics to use to explain to your executive director, your board of directors, that you really need more resources to help you address the issue of cats with URI, for example. This we looked at. This was just to kind of get a sense of, well, how long does it take before an animal develops URI? And once it develops URI, how long does that animal then stay in the shelter compared to the animal that does not develop URI? And I think what you can see here, and we did this by age group, trying to get a sense of, well, geez, is there a difference once you develop URI and the time to recovery? Well, what this data certainly suggests is that our older animals take longer to recover. That's perhaps not surprising, but now we actually have a quantitative measure of that. And it raises different kinds of questions. Should we be getting these older cats out of the shelter, for example? Should they be going into foster care? Should we be looking at other treatment regimens for them? Certainly, if you make changes to a protocol in hopes of reducing the amount of disease, how do you know that those changes are effective? And at the population level, you can't really know unless you've quantified what the level of disease was before you implemented the protocol and then looked at it again after the protocol has been in place for a while.
Okay, so here we have another poll question. Does your shelter monitor its census in relation to its housing capacity on a regular basis? Yes, no, don't know, not applicable. So does your shelter monitor its census in relation to its housing capacity on a regular basis? And the census is your animal count on any given day, and your housing capacity is how many animals your shelter or organization can comfortably house without overcrowding. So we'll give you a moment to answer that poll. Okay, we're getting good results. I'll just give you another moment. Okay, so if you haven't answered, please go ahead and select a choice. Okay, so 40% of you said yes, 24% said no, 18% said don't know, and 19% said not applicable.
So one of the reasons that I asked that question was that in this example, my colleague, Dr. Berliner, was working with his shelter with a very specific goal in mind, and that was to reduce the length of stay of the animals and really move the animals through that shelter. And I have to confess that we didn't have in mind driving down URI rates. We were really trying to work with their very high average daily census, which you see in 2010 was 193. And so by working with the flow-through, and Dr. Berliner will be talking more about this with you next week, by working on the flow-through and bringing down the census, lo and behold, we looked at the cumulative incidence rates of feline URI between the same two time periods that we were working on this, and in fact could demonstrate a significant decline in the frequency of URI. Other questions that you can use your metrics to, we talked about identifying high-risk periods in the shelter for when animals are most likely to develop URI, for example. I'm using URI because, in fact, that's the bane of most of our existences in terms of disease, but you can do this for any disease that you wanted to, looking at kennel cough if you've got a problem with kennel cough in your shelter. It could be giardia, it could be coccidia, et cetera. High-risk groups, looking at those age groups. How are the babies doing? How are the senior citizens doing? So you can begin to see that you can learn a lot about what's going on in your shelter. And I think that looking at these data on a regular basis helps you to formulate protocols that can help you reduce disease. So everyone is always interested in, euthanasia, or the converse, the live release rate. I've used euthanasia here. If we look at individual shelters, these data come from a large urban shelter, large open admission shelter that had a very high rate of URI. But among those cats that developed URI, 43% of the individual kittens were adopted, 49 or almost 50% of the individual kittens with URI were euthanized, whereas those that were not did not develop URI, we instead saw a 64% adoption rate among individual kittens and only a 25% euthanasia rate. The adults, interestingly enough, they had, at that time, they had so many cats that were being euthanized for space that, in fact, you don't see much of an effect of upper respiratory. It's really what's driving their euthanasia is, in fact, over too many cats, too high a volume, too low a flow-through rate. Other factors to monitor, these are just things to think about. This is one of many, many things that you could use your data to do. Looking at duration of illness like we did with the URI. Time to cure. What proportion of cats start on doxycycline, in fact, don't respond and have to be moved to another? Do you know how many cats you have to move? Is there anything peculiar or specific about those cats? Is it younger cats that are more likely to do that? Is it cats that are strays more likely to have to be moved to another antibiotic? We don't know the answers to those questions, and I think the metrics are a key to help us better understand the answers. I'm a great believer in health-related goal setting. I strongly believe if you don't set goals to improve population health, you are likely to maintain the status quo. And I think it's incumbent upon all shelters to think about improving, about reducing disease. Disease causes suffering, and in many cases it's a direct route to euthanasia. So setting goals, and they can be simple goals. I want to reduce the rate of cumulative incidence by 2%, 3% next year. I want to decrease the median length of stay by 5%, et cetera, et cetera. You can think of your own goals. Again, this is not to beat a dead horse, and Dr. Berliner will actually be showing you more of these data next week, but here's a shelter where we really, in looking at in looking at flow-through, in looking at the way we were managing the animals in this shelter, there is a very clear decline from 2010, in 2010 and 2011 from 2008 and 2009, when just after we implemented protocols to really start moving animals through.
Okay, here's our last poll question. Does the shelter with which you are affiliated set health-related goals? Yes, no, don't know, and not applicable. So, does the shelter with which you are affiliated set health-related goals? I'll just give you another moment to answer that. Okay, so it looks like 27% of you said yes, 43% said no, 13% said don't know, and 16% said not applicable.
Wow, that's really exciting. I have to confess to you, I didn't think I'd see quite as much as 27%. So that's really great. And for those of you that aren't, I think that, again, you don't have to set really lofty goals, or you don't have to set 100 goals. Set 1 or 2 goals and set out to plan how you're going to achieve your goal, and then monitor your success toward achieving your goal. So let's talk about some other considerations. This is my time to muse a little bit with you. I'll have to tell you our single biggest frustration in working with these data is the difficulty in many cases of getting the data we need without having to go through a bunch of machinations to try to get it. Certainly there's a number of these you can get from the reports features in your software package, and I really encourage you, if you haven't already, to spend some time looking at your reports in whatever package you're using and looking to see what you can get from those reports. We have been playing a little bit, because of our frustration, a little bit with the monthly data dumps. For those of you who use PetPoint, I don't know if you are currently, whether you recognize that you can get a data dump from PetPoint, which has, what it is actually an access database, which is what they They use a Microsoft Access database to store all of their PetPoint data, and they will send you your data on a monthly basis. And if you have somebody, and it's a little bit hard to find somebody, but if you have somebody who's a little bit proficient with Access, you can actually use that to pull out data that you need. I know that's not a realistic thing for most shelters, hence the plea to you folks to try to put some pressure on PetPoint and other software providers to try to make this data more readily available to you. There are things you could do, specific tallies of interest to you, that you could do with just pencil and paper. I mean, just keeping track of the census in your isolation ward over time. Each day you count the number of cats in your isolation ward and just keep a running tally. The same time every day, count how many animals are in there. If you keep that tally long enough, you'll be able to look at trends and get some pretty good insight, I think, into the number of animals that are developing URI. Now, of course, if you're euthanizing for URI, then you'd have to add those animals that you euthanized to the animals that you have in your isolation ward. I've shown you some nice graphs. Those are not really hard graphs to do. They were all done in Excel. If, in fact, you yourself don't feel proficient enough to do a graph in Excel, probably somebody on the staff does, and if none of the staff members do, then they surely have children who know how to use Excel. And so I don't think it's that hard to find somebody, if you can get the data you want, and PetPoint at least, and again, I apologize for talking only about PetPoint, but that's what I know best. You can get downloads from your reports right into Excel, such that you could then use the data to do graphs. What are the best medical metrics? I don't know the answer to that. I just asked the question because I thought it sounded good. But anyway, my current thoughts are that I think you really need some kind of a baseline annual period prevalence of the diseases that are of most interest to you in your shelter. You could substitute incidence, but prevalence, I think, will give you a good sense of what are the most common diseases that you have in your shelter. And not only what's most common, but what do you mean by common? Is that 5% of the animals in your shelter? Is it 10%? Or is it 80%? You can actually quantify now what you mean by common. And it's also a baseline starting point, so that if you have an outbreak, you can clearly recognize that. Then once you have, even just using the period prevalence with just looking at trends over time, by season, by month, by age, by source. We already talked about the average daily census of sick animals, the percentage of care days. I think these things will begin to give you real insight. And this is not an exhaustive list. You guys are able to think up just as well as I am the things that might be very helpful for you to help manage the care of your population. Some insights and thoughts from what we've learned about working with these data. Be very clear about what the definitions are in your software package. A number of the shelters that we have worked with have age groups defined, and they'll have names like juvenile, adult, senior. But when asked, well, what do they mean? What animals do you put in that category? Well, the woman at the front desk may have one definition, the person working in the back room may have another, the tech that does the exams may have another. So you need to define your age groups if you're using age groups, and write them down and make sure everybody's trained to understand what animals get put into a particular category. Similarly, illness. Where are you going to put illness? Are you going to put it in a diagnosis field, or are you going to put it in a symptom field? In some cases, we won't have a diagnosis. That's okay, but be sure that your people are clearly trained as to how you want the data entered. That's for consistency. It's for standardized, so that when you begin to bring the data back out, you know what it means. So take-home message, you really need to be familiar with your software and the setup and the definitions. And in some cases, you may have been involved in the setup, and that's great. Go back and refresh your memories if you don't remember. In many cases, you may not have seen the setup. and now you need to prevail upon the person that maybe set that up and have administrative access so that you can look at the reference tables to see how the categories were defined. And if you're in the process of setting up a software package, then get involved as a veterinarian. I know that may sound weird, but you should be involved because you're going to be using these data. I was just mentioning that shelter, they had a category unweaned, juvenile, young adult, and senior. Well, when pressed, they couldn't tell me, well, what's juvenile? What is that, 6 months to a year? Is that 4 months to a year? Is it 4 months to just less than 12 months? They didn't have a good standardized definition. Here's a shelter which actually uses age, and if you use age, we all know that there are cats that come in that you don't know what the age is. And so you either got to reserve the actual entry of age to someone who can do it most accurately at the level of looking at the dentition and the body condition and what have you, so that it's not the person at the front desk who actually puts age in, but rather the person at the that is doing the medical exam, or the veterinarian who puts the age in. Recognizing it's not going to be perfect, but it's more perfect than letting somebody who hasn't even examined the animal yet. In some shelters, they'll actually have them put the age in, and then the veterinarian or the veterinary technician will correct that age if they disagree with it at the time of a physical exam. Again, I can't overemphasize, know what's in your denominator. I won't beat this I won't beat this issue to death, but I do strongly recommend that you go and look and see what is your intake category, how are your intake categories defined, and if you're doing summary counts, what's included in those counts. So again, I think you really need to think about your questions very carefully. Do you want to include cats if you're looking at the newly developed disease among shelters or among cats in your shelter? Do you want to count those in foster care? Do they have the same kind of exposure potential? Should they be pulled out of the population at risk? Maybe you don't have very many, so it doesn't really matter. Maybe you have hundreds of animals that go into foster. So just to get you to start to think about very carefully crafting your question such that you get the data that really addresses your question. Be careful if you do, and I'm not telling you you can't change definitions. I think in many cases you have to. We've gone in and actually asked shelters to change their age groupings because they didn't have clear definitions, but keep a log then of those changes such that if you go back and start looking at trends back 5 years, you can know when these changes took place. Maybe the shelter went, for example, from an open admission shelter to a limited admission shelter. And that's going to make a huge difference in terms of looking at potentially length of stay, potentially census. And you need to mark when those changes actually took place. And then just be careful how you interpret your data. Interpret your data in light of what went into the data. This is a very just quick example to show you that we were interested in whether or not if an animal needed to be neutered, did that increase the actual incidence of disease? And we first looked at it by lumping all of the animals in the very top row. We lumped all the animals regardless of age and looked at it. It looks like, in fact, the URI cumulative incidence isn't different in the two groups. However, when we broke it down by age group, if you compare kitten, yes, pre-altered, to kitten, no, not pre-altered, you'll see that you have 0% if the animal was pre-altered, that is, did not have to undergo surgery, and 9% if it did. And similarly, the adult that was not neutered or did not need to be neutered had only a 15% incidence, whereas the adult that was neutered had a 25%. And what this illustrates is a confounding that if we had not separated by age, in fact, the answer to our question was confounded by the age factor. So you want to think about those kinds of things when you start asking your questions. This is a big bugaboo of mine. All of the packages I'm aware of now calculate average length of stay. Average is a measure of central tendency only for normally distributed data. These are clearly not. We really, hopefully, should convince our software packages to be using medians because otherwise you're going to overestimate your length of stay. Maybe that's okay. Maybe it'll be a conservative thing. You'll say, well, I want to reduce my average length of stay from 30 days to 25, when in fact your truly median length of stay was only 25 to begin with, and now you're going to reduce that median down to 20 days. Goes without saying, your data must be accurate and it must be complete. And you don't want a lot of missing data. It raises lots of questions about what kind of inferences you can draw from what you're actually looking at. And then share these analyses. They need to be shared with everyone who has any influence over the care of animals and with a board, because the board holds the key to the purse strings. And if you need money for your medical program, begin to show some of these data to your board of directors. And so you need to start making it, and I know it's hard because everybody's life is so crazy in the shelter, but forcing yourself to make an examination of the shelter data a regular occurrence of what you do and part of what the role of a shelter veterinarian is. So the goal of every shelter, hopefully, is to provide for the very best welfare of the animals in their care. And I think that we want to, of course, reduce suffering, and disease causes suffering. And in doing so, in reducing the level of disease, we're also saving lives. And if we can minimize the euthanasia rate or increase the live release rate and minimize the amount of suffering that's going on in the shelter due to disease by using metrics, I think it is incumbent upon us to do so. So I want to again thank Maddie's Fund, not only for this presentation tonight, but of course for your funding and long-standing support of the program at Cornell. I want to thank my colleagues, Dr. Greenberg and Berliner, who have been instrumental in helping me work with these data and really begin to affect some changes in shelters so that we can monitor with these data. I want to thank Sandra Newberry and Kate Hurley for all of their work on the metrics of length of stay and capacity, and all of those that preceded them working in the large animal arena in herd health. They have for years been using metrics. They fully recognize the value of using metrics to help them manage the health of animals in herds. And of course, I want to thank the shelters who have allowed us to use their data and to work with them to try to learn more about how best to use these measures and how best to help them with those measures. So with that, I will take questions.
Okay, well, we have some time for a few questions, and I'll post the questions on the screen. So let me push this question. So I'm not affiliated with a shelter, but I am trying to convince them to improve their care. Their priority is cost. How do I make them see this is a money-saving issue?
I guess, so when you say a money-saving issue, are you trying to, what I don't know is whether you're trying to convince them to actually purchase a software package and use it. I'll assume you have a software package. I'll assume that they're entering some data, but maybe not the medical data. I think what you need to say to them is that when animals get sick, it costs them money, and that when you develop a budget, if you can reduce the amount of disease in your shelter by benchmarking where you are and actually demonstrating that you're diminishing the amount of disease in your shelter, that saves money, because as I pointed out in an earlier slide, we have some data now that clearly show that animals that develop disease stay longer in the shelter, which means more care days, which means more staff hours, and that all translates into money. So that's just one argument that I would use with them. And also I think I would go back to, yes, it's a money issue, and we all have to be mindful of money, but it also goes to the mission of our shelters. They are humane organizations, and if we must do everything we can to minimize suffering and to minimize euthanasia by keeping animals healthier such that they don't have to be euthanized.
Okay, so here's the next question. Do you look at environmental factors in disease, for example, housing of cats away from dogs, giving cats a box to hide in, or other elements to reduce stress? What about the amount of human contact individual animals receive, for example, human-animal bond?
Wow, those are a whole bunch of things that we haven't really looked at. So, for example, you could look at if you had cats that were housed close to the dogs, a group of cats, let's say one particular ward is very close to where the dogs are, and there's a lot of noise, you could look at the URI rates in that ward compared to a ward that was removed from the dogs and had less noise. I think it's a lovely little experiment one could do in their own shelter to look at among cats that are provided with hide boxes. Do they have a lower prevalence and or incidence of URI compared to those that don't, et cetera, et cetera. I mean, you're beginning to recognize that there are all kinds of questions that if we had good data, we could begin to address. And we could begin to address them in our very own shelters as opposed to waiting for somebody to do it in a research project. Because when you do it in a research project, that researcher is only going to be using 2, 3, 4 shelters because of the feasibility issues. And if you could do it in your own shelter, with your own facilities, with your own staff, you could actually begin to see what the impact is in your own shelter. So yes, you can certainly look at environmental factors.
Okay. So my concern is that after analyzing this data, shelters may use it to euthanize sooner rather than later whenever they can. Have you seen this happen?
No, I haven't seen this happen. I'm trying to envision the circumstance under which they would want to euthanize sooner. If they're choosing to treat animals, I think we can demonstrate that we can decrease the whole amount of the whole euthanasia rates that go on in shelters. And if we could show them that we could reduce the euthanasia rates, I don't think that they're going to be jumping to try to do it sooner. At least I hope not. Unfortunately, I can't ask you in person this question. Are you thinking that because we're now showing that if they're in the shelter, it increases their length of stay if they develop URI? I mean, I think most shelters that make the commitment to treat recognize that by making that commitment, they are going to increase length of stay. So I don't know if I've answered your question, but I would go back to, I think that we can clearly demonstrate that by reducing length of stay, decreasing census, that will translate into reducing rates of disease, and that will translate directly into increased live release rates and decreased euthanasia rates.
So what are the advantages of prevalence over and vice versa?
Right. So the advantages of prevalence, and the reason that I was suggesting that you could start by doing prevalence, is that you don't have to think quite as hard about taking animals out of the denominator and numerator who may have already had disease. But they answer really 2 types of questions. Incidence actually addresses the risk of developing disease in your shelter. So let's take the situation where a shelter in 2011 wants to compare itself to 2010, but in 2011 there was a huge seizure from a cruelty case, a hoarding case, let's say, and in that, so they brought in 100 cats, and of those 100 cats, 50 of them had URI. It may be that the prevalence of URI looks higher to you in 2011 than in 2010 because you had this big bolus of sick cats come in. Now, should that count against the shelter? I would argue no. It shouldn't count against the shelter. It's because the shelter was doing its job in helping a cruelty case. So prevalence doesn't distinguish between whether they had disease when they entered or whether they developed it during the course of the year. in that same shelter with a hoarding case, you could have seen, it's conceivable, you could have seen an actual decrease in the incidence of URI, of cats developing disease in your shelter, when in fact the prevalence had gone up. So prevalence, any question that has to do with just the burden in the shelter, whether the animals developed their disease in the shelter or they came in with it, you will want to use a prevalence measure. Incidence measure really looks to the question of what's the risk of these animals getting sick while they're in my shelter.
This is we just have time for one more question, and here's the question. What options are there for monitoring where in the shelter new cases of diseases are occurring? Or rather, how would someone go about recording data to determine the area in the shelter that was the source of an outbreak?
You know what? Right now it's really, really, really hard in Pet Point. We have been trying to track disease by location. The problem is that location, in at least the shelters we've been dealing with, is not accurately and frequently entered into the computer. So, for example, cat starts out in Ward 1. It gets moved to Ward 2 for whatever reason. Nobody goes, the staff don't routinely go to the computer and say, this cat has moved today, record the date, and now it is in Ward 2. Until very recently, the other problem, besides the fact that staff had not been religiously recording changes in location, was the fact that you couldn't track that once you had a location, so a cat came in, it was put in Ward 1. Then if somebody came and moved that cat and put in Ward 2, Ward 1 was replaced with Ward 2. There is now, at least in Pet Point, a way to track the history of where the cat has been in the shelter. But there's no easy way right now, at least, in Pet Point, and I can't speak to the others, but at least in Pet Point you can't easily say, okay, I want to pull up all cats that develop their URI in Ward 2. So it's something we're striving to look at, where we really are interested in whether location plays a role in the spread of disease, but at least in our hands right now, it hasn't been an easy thing to do.
Okay. Well, thanks for answering those. That's the end of our event, and we'd like to thank Dr. Scarlett and all of you for your time tonight. We hope you'll join us on March 15th, 1 week from today, for In One Door and Out the Other, Practical Flow-Through Planning for Animal Shelters with Dr. Elizabeth Berlinger, Director of Clinical Programs for Maddie Shelter Medicine Program at Cornell University. We'll be emailing information on how to register for the webcast to those of you who haven't done so already, and we hope we'll see you there. We're very excited about this webcast. For those of you who signed up to receive RACE CE, we will be emailing you your certificate within 2 weeks' time. Please click the link to take our survey. It may have been blocked by your pop-up blocker or be on a different screen. If it is, we'll be emailing you the link, and we'd appreciate it if you could take a few minutes to respond to it. We also invite you to come to maddiesinstitute.org and sign up for our mailing list, and to follow us on Facebook at facebook.com/maddiesinstitute and on Twitter at maddiesinst. That's Maddie's INST. We hope you checked out the resources and the widgets at the bottom of your screen, but if not, we'll be emailing the links to you, as well as contacting the winners of our Maddie's Infection Control Manuals and sharing links to the archived version of tonight's webcast. Thanks again for being here with us this evening, and good night.